All right. Thanks for coming. Hi, how are you? So does anybody have questions from the things that we've gone over so far from the last couple weeks? Labor stages. Pelvic model will be here next week, not this week. Nothing? No questions? That's cool. Okay. All right, so this week we're going to do mostly focus on pain medications and what your options are. We'll say pain management, whether that be comfort measures that you're using, whether it be pain medications, epidurals, all that. We're going to cover all of it in terms of, what choices you have and how those choices will affect your labor benefits and risks kind of thing. We'll start by going over the brain handout again, because that one is how we're going to address most of these questions. This was last couple weeks, so you don't really need to find it, but what we're going to do is just go over who wants to tell me, one of the partners, raise your hand, and who wants to tell me what brain stands for without looking.
Benefit, risk, alternatives, intuition, and nothing.
Yes. Okay. So, good job. Sorry, I don't have any prizes today. Yeah, so this is going to be what we're looking at for each one of these options. And mostly as far as the medical, some of the non-medical, you'll sort of understand how they're going to play into it. So starting out with your first class 4 handout, 4 of 6, what's in your bag? So what are some comfort measures that you can use? And I know we've kind of touched on these things before. What are some comfort measures that you have used or can use that are non-medicinal, that are not non-medicinal, but that are like physical comfort measures? A heating pack, good one. Music. Cold pack on the other side of that, yes. A good thing to do for that is you can just get a sock and fill it with rice and tie one end of it. And that's a really simple, you can heat it up in the microwave, you can put it in the freezer. It's a really simple hot cold heating pad that you plug into the wall is a good one too. So, you think of any more?
Oh, I left you a message. We're doing our birthing class, but I said just let me know.
Massage, right? Massage. Aromatherapy, if you're interested in that. As a doula, I don't provide aromatherapy. It's out of my scope of practice technically. If you have oils that you want to bring, I'm happy to help you.
Wow, are you out and out already?
You like, and suggest them during labor, but they have to be your oils. They can't be mine. So music playlist. Have you started your playlist? Start your playlist. Every time you listen to music, add a song to it. It can be a really great, music that makes you feel good. Songs that you love to listen to. I have a few playlists that I use too for my 2 births, but they're different. They're totally different because basically when I started, I don't know if you use Spotify or Red or whatever but start it now because it can be a really, really great tool to get you up and moving, dancing to your favorite songs, feeling nostalgic to songs that you may have listened to in the past. It's a really powerful tool that on your body chemistry. If you feel good, so you said massage. Anything else you guys can think of? Comfort measures that you would use that are not medicines that you would get in the hospital?
It might be weird, but space, like Paul take Christian somewhere and I just have like some time.
Yeah, that's great. Yes, alone time is a totally legitimate answer. Anything else you can think of? A tennis ball? Or like a massage ball, you can use it. So counter pressure and hip squeeze are 2 of the ones we're going to actually get up and practice today. But you can actually, oh man, and I took my massage ball out of my purse this morning. I was like, my purse is too heavy. Well, anyways, a tennis ball is a great tool because you can apply even pressure, and it's a good way to not have your wrist be dying partners at the end of the evening or experience. So then you have things like hip squeeze. Again, we practice that one. And then counterculture is usually on the sacrum. Yeah, so those are some good what's in your bag comfort measures. So little things you can bring or have around. Another cool one that I've seen is actually combs. So like little fine tooth, you know, the ones that are just like a single comb. And you can put the teeth of the comb into the crease of where your fingers meet your hand and close your hip fist around it and press. And you'll see in the video, one of the things that she's going to talk about is a theory of pain that is called the gateway theory, that essentially says if you overload your brain with one type of stimulus, then you're not paying attention to some of the other stimulus, right? So the idea being that you have this, I think also, from what I understand, these nerves are connected to the uterus somehow. I don't know exactly what that is, but I tried that in my labor and it felt great. I didn't necessarily think that it dulled the pain as much as it just felt good and was a good distraction. But I have 2 combs that I carry in my doula bag, and it's kind of an interesting, like, you can squeeze them if you want. So that's something. And these are things that you can put in your hospital bag, right? A crock pot to put warm rags in, and then the plug-in heating pad are 2 really, really great things that you may not think to put in a hospital bag, but that you could, you know, or have in home that can be used as comfort measures. So the next thing on the list says bring home to the hospital. So if you're leaving your home for birth, then one thing you can consider doing is putting together, you know, bringing your own pillows, your own pillowcases, your own blankets, string of lights, whatever it may be, a family photo, things that make it feel, you know, a couple of sheets to put up. I've seen someone put a sheet up over the window so that they couldn't see the hospital curtains. It just was a sheet that was familiar to them. Maybe a bed sheet, whatever it may be. So those are some ideas just for little things that you would be surprised how much creating, you know, when you're creating your safe space, when it's familiar, when it feels good to you, it can have a huge impact on the way that you are responding to the people who are coming into it, rather than feeling like you're in a, you know, I had another mom one time who was like, she hated hotel rooms, and a hospital room to her felt like a hotel room. And so it was very anxiety inducing because she felt like she was in a hotel room. So one of the things that she did to alleviate her anxiety was she brought her home house cleaners. She brought her, like, and so when she got to the hospital, she was admitted, and the first thing she did during her labor was clean the hospital room, just like she was cleaning her house. It was the strangest thing I've ever seen, but she said she felt a lot better afterwards because it smelled like her house. It smelled like her home cleaners, and she felt good about it being clean and not about it being a hospital. So that was her thing that made her feel a lot better about that space. So something to think about, the way that, you know, part of what we do is, like I said, create that safe space. You want to feel comfortable. So whatever those comfort measures are, setting them up ahead of time and making sure you've got them with you. So what will the hospital be like? And I apologize if some of this is sort of tailored towards hospital. It's definitely, you know, you find that balance. Unwritten rules of the hospital. So policy. What are some of the hospital policies that you run into? Anybody have any ideas what they might be? Yeah, so that's a tough one. And yeah, I've never had that happen, but it's,
so you can have a conversation with people who have, like,
right.
tapped on the shoulder and you just say this about Kate.
Right. Well, so you mean the birthing person tapping the doula?
No,
The other way around.
Yeah.
Right. Right. So yes, that's a good point. I do not speak for you. I can be a facilitator to communication. I might say, did you have questions to ask? Did you want to bring something up? Do you have an issue with anything that's happening right now? You're right. So an example of that would be like pushing phase. Nurses' hands are in places maybe they don't need to be. and mom doesn't realize it because she has an epidural. So it's not my place to say, excuse me, miss, you need to get your hands out. This is not, but I might say, mom, are you okay with what's happening right now? This is what's happening. But yeah, so that's one of the things that, as far as hospital policy, I think that as far as doula work goes, it's typically, let's see, how do I put this? There's never a situation, I don't think, where I would say something that would get me kicked out as much as I would potentially be a set of eyes that is unbiased or that is biased towards the birthing family, if anything. And so I think in a lot of situations, a doctor will be more cognizant of that and be more aware that, that I'm watching. And I've had that situation. Well, yeah. So good point. Any other hospital policies that you think you may come across when?
I can also say a lot of hospitals, once your water breaks, they say you have to have it 24 hours. So
That is
your
a
doctor's
hospital.
like, let's break your water.
Yes.
Go faster.
Yes.
And look at C-section.
Yes. So AROM, artificial rupture of membranes. We will talk more in depth about that in the next class, which is going to be interventions. But yes, typically hospital policy states if you have a ruptured bag of waters that you are put on a clock of about 24 hours. So in bold here, you'll see that hospital policy does not trump patients' rights or requests. Now, in one of the videos we watched that was a Mama Natural, I don't know if you guys on the video, if you guys noticed this rewatching from last week, but what she said was, you always have to be aware, you always have to be not necessarily fighting for your right to have a natural birth, but yes, right? You do. You need to know that just because someone says to you, our policy, if you hear that, that's a red flag to say, okay, but your policy is not my birth experience, okay? And you always have the right to push those boundaries. And if you doubt it, ask me, because I can be the one to say, no, you're still definitely within your rights as a human to have those. You may come upon the situation where they're saying, well, you have to do this, well, you have to do this, and no, you don't. I won't maybe say that in front of a nurse. I'm not going to turn to you and say, you don't have to do that, but I'll say, do you want to talk about it? And then you are the one who has to ask for space in that situation and turn to that nurse and say, can you give us a second to discuss the situation before we make a decision? Does anybody have questions about that? Because I think that's one of the most important things that I want you to take out of this class is that you don't have to, you always have time. There is never an opportunity that you don't have time to talk about it. And if you get that feeling, then that's when you're going to ask the questions. Is mom okay? Is mom's heart tones, blood pressure, everything's okay with mom? Is baby okay? Do baby's heart tones look okay? Is baby's, what? So outside of that, can we have time? And if you don't have time, they're not going to be sitting there explaining something to you. They're going to be saying, we have to do this now, right? And even then, you should still have time to say why. And they'll say, your blood pressure is exceedingly high. We're afraid that if we don't take the baby now, that you might hemorrhage or bleed on the table. So obviously that's a reason for a C-section. However, beyond that, if you hear hospital policy, or if you hear, let me go ask the doctor if that's okay, that should be the red flag to you to say, all right, well, we need to regroup here. So good point. So hospital policy typically is about 24 hours once your water ruptures. Usually it doesn't take that long, but if you do have a situation where your water ruptures and you start to feel like you're on a clock, I'll hopefully be there to remind you that you're not on a clock. So another one that is typical of hospitals is to require a cervical check before you're admitted. Usually they want you to be in active labor, and active labor is anywhere from, what dilation considered active? Right. So 4 to 5 centimeters is active labor. And so how would you address the situation coming into the hospital? And I don't know, I haven't had a prenatal with you guys, so I haven't spoken with you particularly about this topic. And I think Joy and Paul, you guys, I haven't spoken with you guys particularly about this. I remember Joy asking the question about the cervical checks, but so you guys may be totally fine with a cervical check, and that's okay. However, if you're not okay with it, how would you address that if you come into the hospital and they say, okay, well, we need to check your cervix to make sure you're in active labor, and you don't want cervical checks? How would you handle that situation? Do you have any idea? Okay. So
You gotta do more than just, that sounds simple, just say I don't want to. But
okay, so we'll play. Okay, so you just came to the hospital. Okay, ma'am, we need to go ahead and check your cervix. If you can please lay down on the table, we want to make sure that you're in active labor before we admit you to the hospital. Okay, so our policy is that we have to check your cervix before we admit you to the hospital. Let me go check with the doctor and make sure that that's okay. I come back and say, okay, the doctor really wants to have a cervical check before we admit you. So if you would please lay down on the table so I can check your cervix.
You gonna send me home?
Maybe. So at that point, yeah, you can still say no thank you, and she just might keep trying, and you just keep saying no thank you. And then there would be a point probably that you would reach where you say, clearly you're in active labor, okay? The nurse is gonna realize eventually, and what they'll do is, either you have a waiting room, or you'll be in a triage room, or you will be put into a room for labor and delivery, but you won't be admitted yet. Or you can go home until if you decide that you're feeling like it, you're ready to be there, you want to get checked, or you want to go in, you feel safer at the hospital. Can you put us in a room and then give us a little bit of time? I don't feel comfortable going home yet, but I feel more comfortable being here. However, I would like to decline a cervical check. And that would be just something you keep saying until you until you win.
Thank you, but I'll do my own service.
Yeah, you could do that. And probably not. But it doesn't mean you can't say it,
Or like your partner.
Yeah.
But it's not trendy.
Yeah. So, that's totally fine. They may say, I don't know what they would say to that.
Not admitted. Or
Yeah. Well, and that's what I'm saying. Like,
okay.
you can always, usually it's not an issue to have to be put into a room in labor and delivery before. And a lot of times the reasoning behind that is they don't want to fill up those labor and delivery rooms with moms who are at 2 centimeters who are going to be laboring for a lot longer time before, it could be another 2 days before you have the baby. Hopefully not, but I think that, that's the reasoning behind that. And then, of course, the situation will come where we say, if you want to labor at home as long as possible and get to the hospital in active labor, then I'm never going to check your cervix. However, I have been a pretty good judge in the past of where you're at, right? So saying, by timing contractions, are there alternatives to my cervical check? Can you time some contractions, right? Can you put me on the monitor and get a good strip so that I can, whatever. Okay. Any questions? Questions about that? You guys here got it? You guys have any questions? Thumbs up, thumbs down, thumbs up? Okay. So that sort of covers the top couple ones of triage, check-in versus being admitted, vaginal exam, active labor. So when you come into the hospital, they're going to check things like your vital signs in your midwife when she gets to your house. She's going to check your blood pressure. They're going to check your pulse and your blood oxygen level. They're going to monitor the baby. A lot of times, again, this is fetal monitoring is next on the list. We'll talk much more in depth about that next class, but getting a good strip. We need to get a good strip. So what they're talking about is we need to look, and it's usually 15 to 20 minutes, and they want the monitors to stay in place for 15 to 20 minutes so they get a good printout strip of heart rate, And then heart rate responding to contractions to make sure that baby's doing okay. Are there any alternatives to this? Yes, you can have them use a fetal Doppler, which is like the little handheld Doppler that has the heartbeat monitor, right? Hospital policy says that we need to get a reactive strip before we can allow you to go unmonitored, is usually what they'll say to you. Again, that's something that make a decision on. If you have issues with things like that now, you should definitely talk to your care provider. I'll give you guys a handout next week on, and you can actually get it for yourself if you want to read it early, but on the website, Evidence-Based Birth, there is a article about fetal monitoring, and it's really interesting to read about how fetal monitoring affects labor. So if you want to do a little bit of pre-work on that, you can go read some of the evidence-based birth articles about this. Hospital policy on food and drink. We kind of touched on this last class. One of the things they may want to do when they admit you is put in an IV, HEP lock. Again, hospital policy never trumps your rights as a patient to decide what you want and what you don't want. If you're okay with having a HEP lock, that's totally fine. HEP locks have lots of benefits. If you do need an IV medication, or if you do need to have an emergency surgery, but like if you really think about it, if someone comes into the ER and they are unconscious, do they have time to put in a HEP lock? Yeah, always. They always put in an IV to anyone who comes in ever, and they are good at doing it quickly. There's a reason for that. So something to consider on HEP locks. As far as IV, I mean, as far as food and drink during labor, the most common hospital policy is that no food and drink is allowed during labor except ice chips or clear liquids. And I will say that my opinion on that is that it is bull crap. And you can do whatever you want. If you want to eat, you're pregnant, eat, okay? Like, so we'll talk about the in-depth again, benefits and risks of that, but that one's a touchy subject. Okay, so if I want to avoid pain medication, what will help me do that? So we're gonna watch a little short video here. This one is about pain theories and pain versus suffering. Let me find. Unable to open. Did I delete something? I'm going to share the screen with you guys. Give me 1 second. So if you want to read this transcript later, you're welcome to. I'm going to play it and then I'll share it with you guys. Give me 1 second. Let's see, Zoom call, share screen, Google Chrome. Okay. You can see the screen on the video side. You guys can see the video? Okay. So this is, well, she'll tell you who she is.
Welcome to the Evidence-Based Birth series, all about pain management in labor. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. In this first video, we're going to do a quick overview of the topic about pain in labor. So pain seems to be the #1 thing that a lot of people worry about when it comes to being pregnant and going into childbirth. I work with a lot of college students, and in the beginning when I start working with them, a lot of them are terrified of the pain of childbirth. What most people don't know is that there's two main ways that you can look at the topic of pain in labor. Several researchers named Leap and Anderson proposed these two different viewpoints or perspectives. One perspective is the perspective of pain relief during labor, and the other is, quote, working with pain or coping with pain. Many doctors and labor and delivery nurses believe strongly in the pain relief perspective. They may believe that pain during labor is unnecessary in today's society and that we should eliminate pain and that the benefits of pain medications always outweigh the risks. Some of them may not understand why someone would want to go without pain medication during labor. And that's because a lot of nurses and doctors were trained in medical school and nursing school that it's very important to assess people's pain and eliminate it as much as possible. On the other hand, a lot of people believe in the coping with pain or working with pain philosophy. In this perspective, people believe that pain is a normal part of labor and that it's necessary to entice you to move around and try different positions that will help the baby come down and out. In the right environment, an environment that feels supportive and private and lets you feel not anxious, people can better cope with labor pain in an environment like that because they feel safe and supported. Also, it helps them release natural pain relieving hormones called endorphins. People who believe in the coping with pain perspective also believe that there is a difference between pain and suffering. Penny Semken is a famous doula and author who has written a lot about the topics of pain versus suffering. She teaches people that you can have pain without suffering. You can also have suffering without pain. They don't necessarily have to go hand in hand. For example, people may experience pain without suffering during things like running or training for a marathon or undergoing a planned surgery, or even for some people, having labor may be painful but not suffering because they're prepared for it and they have lots of support. Things that can help you cope with pain and prevent suffering include things like being educated so you're not as scared or fearful, companionship, reassurance, touch, feelings of safety, and other positive factors. On the other hand, it's possible for some people to be pain-free and to still suffer. People with an epidural might feel no or little pain, but could still suffer emotionally. They may feel distressed due to a long labor, to the numbness that they're feeling in their body, to feeling isolated or alone, or they may suffer if they're worrying about their baby for some reason. Or you could have a situation where both pain and suffering are happening at the same time. Many healthcare providers that I've worked with are very attuned to their clients and noticing whether or not, if they've crossed that line from pain to suffering. I prefer personally to talk about pain management because even with medications, sometimes it's impossible to completely relieve pain. So I believe we should talk about managing pain and helping people learn how to do that with as many methods as they need. Now, pain management strategies during labor can be divided into two different kinds of approaches. There are pharmacological approaches, which are using drugs and medications, and there are non-pharmacological or non-drug approaches to managing pain. In this video series, some of the drug approaches that we're going to talk about include epidurals and spinals, nitrous oxide, also known as laughing gas, and drugs that they can put through your IV to help with pain. Now, researchers think our bodies perceive pain in a couple different ways. The first way is by how intense the pain is, and the second way is how we perceive the pain to be unpleasant, how unpleasant it is to us. Now, there are several different non-pharmacological approaches or non-drug ways to manage pain that help reduce either the intensity of pain or the unpleasantness of pain, or both. One of the ways that we can help manage pain during labor without using drugs is called the gate control theory. This is a really cool concept. Basically, the gate control theory says that if you activate your nerves in a non-painful way, the same time that you're experiencing pain, that kind of blocks the pain signals from reaching your brain. That's because there's a gate. There's a limited amount of information that can go up to your brain at once. And if you flood the nerves with non-painful stimuli, that prevents the painful messages from getting through. For example, I have a lot of migraines. I have chronic migraines. And I can have really intense pain in my head, like it feels like there's an ice pick coming out of my brain. But if I eat a spoonful of ice cream, the second that ice cream gets in my mouth, it's so sugary and sweet and creamy, the pain in my head actually goes away. I can't feel it anymore because of the gate control theory. My nerves are being flooded with non-painful stimuli, so the painful messages can't get through. Now, that does not make the migraine go away, and as soon as I finish eating ice cream, the pain comes flooding back. But that's just one example of how we can use that gate control theory to manage pain in labor. So what are some ways you could help block painful messages during labor? Well, some things include like laboring in a warm tub of water, having someone massage you during labor, or put pressure on your back with their hands, positioning yourself in movement and using things like birth balls. You can even use warm packs or little TENS unit, spelled TENS. All of those things help flood your nerves so that the painful messages can't get through as well. Another really important way that you can help manage pain during labor is through controlling your mind. That may sound kind of crazy, but scientists call this the central nervous system control method of pain management. By controlling your mind and what you're thinking, you can actually help control the unpleasantness of pain. Some examples of central nervous system control include taking childbirth education classes, hypnotherapy, or using hypnobirthing or hypnobabies, continuous support like from a doula, aromatherapy, music, and relaxation and deep breathing. Now, some people might be skeptical and think that these non-pharmacological approaches don't work. But in 2014, researchers looked at all the research that had ever been done on non-drug approaches and found that they were actually very effective. Both using gate control methods and central nervous system methods helped decrease the chance of your needing an epidural and greatly increased your chances of being satisfied with your birth. When people were randomly assigned, like tossing a coin, to either having a drug approach or a central nervous system approach, researchers found that people who had the central nervous system approach offered first actually experienced fewer cesareans, fewer forceps and vacuum-assisted deliveries, less use of Pitocin to stimulate labor, and they also had a shorter labor on average. Now, what was most effective in this study was when researchers combined multiple methods and tailored them to the individual, and also having continuous labor support from a doula was one of the most effective methods. ACOG, the American Congress of Obstetricians and Gynecologists, actually recommends that people in labor be offered non-pharmacological methods because no adverse or no side effects have been found to these methods. Some of the methods that we're going to talk about in future sessions include water immersion during labor, relaxation techniques, acupuncture and massage, and support from a doula. So in summary, people can feel intense pain during labor, and we can help people and you can manage labor using both pharmacological and non-pharmacological approaches. For some people, all they will need is non-pharmacological approaches. For others, they may require pharmacological or drugs as well. However, it's probably best if everybody went into childbirth well-equipped with a toolkit of things that they can use to help manage pain and cope with labor. Even if you've chosen to use medication, there is going to be probably a period during labor when you don't have medication, in which case those non-pharmacological approaches might be very helpful. And also when people are using those first before they get medication, they actually report increased satisfaction with their childbirth. Thanks for listening. Bye. To learn more and subscribe. Thanks. Bye.
Okay, I'm gonna stop share. All right, feedback. You guys can come back. So everyone who's here is already taking the first step, which is childbirth education courses, right? So part of the reason that works is you feel more important, you feel more powerful because you know what to expect, because you feel like you have that to your kid. So props to you guys. What else did anybody want to tell me what their favorite part of that was, or what they remembered? What stuck out to you?
You love ice cream.
Eat ice cream. I know, I love that. She's like, when I stopped eating ice cream.
So, don't ever stop
Yeah, good example, right? Anything else? Guys on that end, on the video end? Feedback? You don't have to. Just giving you the opportunity. You good? Okay. Okay. Yeah. So I really like that video because of the way she compares her the pain approaches. So managing pain versus pain relief. So one of the things I like about it is that she points out that many medical care providers and nurses are trained in med school to manage patients' pain. So this comes from more than just childbirth, right? This comes from all medical fields that they had to do clinicals in. You know, what's the first thing they're going to do? You see those pictures on the wall whenever you go into a hospital room, and it's like, what's your pain scale? And it's got the little faces, and you say, 1 out of 10, what's your pain scale? So that's a good point, I think, to make, because it kind of puts it into perspective. A lot of times I think in a hospital setting, when you're offered pain management, you're not offered, a nurse is not going to come in and be like, oh, honey, can I rub your back? Right. And so it's a really interesting, I think, thing to note, that the reason that they have that approach to managing pain is that, that's the way they're trained. That's what they know. So the other thing is, let's see, what was the other thing she said? I don't know. I'll come back to it. So on your next handout, now this is into some of the medications. I had another handout for you guys in my scanner. I could not get my scanner to work, so I'm going to go through it, and I will be able to, on the way home today, go by Office Depot and have this guy stand in. I will tell you what the handout is, but it is pain medications and their effects. And this is a 1, 2, 3, 4 pages of all of the different types of medications that you could potentially be offered, and it lists their desired effects, other possible effects, precautions, procedures for safe use. So it's just I'm going to talk about some of them here, but it's a lot more in-depth information about those. So you guys will have that to look over if you want to. So the first page you'll see is so I'll read this to you. It says, labor pain originates as pressure, stretching, or compression involving tissues in the uterus, vagina, or pelvic joints. Contractions of the uterus, dilation of the cervix, and the baby's movement through the pelvis create the pain. Nerve endings in these tissues are stimulated to send pain impulses over the nerve fibers to the spinal cord and brain. Normally, pain in our body signals something is wrong. However, in labor, this pain means something is happening. So it's a different, I'm sure you've heard it before. It's a different kind of, your automatic reaction to pain is typically, something's wrong. I got to get away from this. And so the point of you being here, and the reason that, you do all this preparation, is to retrain your brain for childbirth to think, this is helping me meet my baby. This is bringing my baby to me. So it's definitely, and I like this statement. Comes from the birth partner, but it just kind of is a cool, when you're in it and you feel it, you're not thinking about what exactly is happening. So we have, these are some definitions, the bold words. We're going to go through and read the bold words first and not the little open circle points. If you guys want to start, analgesia is reduction of pain and labor.
Anesthesia, loss of sensation, including pain sensation. Anesthesia drugs take away all feeling.
Systemic. Taken by the bloodstream, affecting the entire body, reaching the baby. Concentrations similar to those reaching the pregnant person.
And we're going to skip down to neuraxial.
Neuraxial, affecting areas of the body that are supplied by specific nerves coming from the spinal cord. Medication that interrupts transmission and helps create local, affecting specific tissues in childbirth, the cervix, vagina, and perineum. A local anesthetic blocks the feeling provided by nerve endings in these tissues.
Do you guys want to read general anesthesia? Maybe? I see you searching. That's okay. So general anesthesia, complete loss of consciousness caused by systemic medication, a general anesthesia. Okay, so those are definitions, and then in-depth, some more information is kind of put in here. I tried to group them by sort of the type, but so for systemic, taken up by the bloodstream, affecting the entire body, and reaching the baby in concentrations similar to those reaching the pregnant person. So I want you to hear that in a way that reaching the baby in concentrations similar to those reaching the pregnant person. So if you think about what that means, if you've been avoiding alcohol, avoiding caffeine, avoiding taking prescription medications, and then come into labor and you choose to use an opiate, you're also giving that to your baby. So tranquilizers, sedatives, narcotics, so an opiate would be a narcotic, and synthetic narcotic-like drugs. These act in the brain to reduce the recognition of pain and the reactions to it. I've been trying to catch my ums, you guys, it's ridiculous. Because the effects of these drugs on baby are profound, they must be given early enough to metabolize and be excreted before birth. If there is not sufficient time for this, a narcotic antagonist is given to baby at birth. So another part of that, when medications are used is another part of the handout that I didn't get to scan. But basically, it's a really cool visual to see. It has dilation from pre-labor all the way up to birthing and pushing phase. And so you see some of the ones, I'll show you. It's kind of hard to see, but there are little arrows that tick and show you where things can be used. But it's really interesting to think about hearing, you hear that, but so what do you do when somebody overdoses on an opiate? They get Narcan or adrenaline, right? And so that's essentially the reason that some of these drugs can only be used in the first stage, early dilation, is for that reason, that the baby comes out and the baby is still on opiates. And so they have to give the antagonist to that. Most of the time, your care provider is going to be, if you choose to get a pain medication that is not an epidural, they will want to check your cervix to see where in labor you're at. The reason for that is that if you dilate quickly, if you're at 6 centimeters and you're trying to avoid an epidural, but you want to get something like a sedative or a narcotic, then if you're at 6 centimeters, they may say, okay, we can give you a light dose. If you're at 8 centimeters, they may say, we're really sorry, but it's too late for you to get these drugs. And it's because of that. It's because they don't want your baby to come out and be dopey, basically. So these drugs can reduce anxiety and help mothers sleep, as well as relax deeper between contractions. The peaks of contractions, however, are often as intense without the medication. So an example of this would be, and this is something that in some hospitals you can get it. Most are still working up to this, but I'll use nitrous oxide as an example because it's just a perfect example. But when you take nitrous oxide, how many of you guys have been to the dentist and had laughing gas? Right? And so if they put the laughing gas mask on you and you're kind of like woozy, most of the time you just pass out. But if they give it to you for a second and then take the mask off, what happens is that you go to that place where you're kind of like, just like drowsy. And then as soon as you start to breathe oxygen and metabolize that, then you come back to, and what happens is that you sort of have like a vague memory of what happened, right? So what you see and then some of the other drugs, some of the other narcotic-like drugs that they can give you that are like IV, systemic IV injections. So systemic, again, taken up by the bloodstream. So if they give you a shot of something, an IV pain relief, what you'll see is that, and this is partners for those of you who, if you choose this route. So what you'll see is that mom passes out between contractions. She's not unconscious, but she's not. So when you get to the peak of the contraction, they're often as intense as without the medication. Often it just doesn't bother her as much. But one of the things you run into with those drugs is that when the pregnant person is passed out, they don't feel the start of a contraction, so they don't get that hill climb, and then they wake up at the very top of that contraction and they're completely overwhelmed because they weren't expecting it, they were passed out, and then they have this like, oh my God, it's like really intense, and then they start to come back down. So partners, how partner can help is to stay awake even though mom is sleeping, and be aware of when the contractions are coming to help the person get into a rhythm before the peak so that it doesn't suddenly overwhelm them. So this could be like, hey, the contraction's coming, let's go ahead and start your rhythm, whatever it may be that you've been doing. And even though you're kind of woozy and drowsy, you're still expecting to get that peak. You're not just waking up to the peak of the contraction. Does that make sense? So those are some of the systemic, and I wish you guys had this. I'll be on top of it. Systemic, let's see, some examples. Sedative barbiturates, so morphine, phenobarbital, secobarbital, some of the tranquilizers, promethazine, diazepam. Any of these can be, some of them are in a pill form, but most of the time they're going to be just injected, and they will have a shorter shelf life. They only last for a couple hours. If you get them early, you can come back and get another dose before you get to full dilation. But that's sort of the reaction that you'll see there. Yes, and nitrous oxide, gas and oxygen mixed together. Okay, so neuraxial drugs affecting areas of the body that are supplied by nerves coming from the spinal cord. So you have neuraxial analgesic, either injected directly into the lumbar spine area, into spinal fluid, or injected just outside the spine. So this is describing the epidural. Absorbed across the membrane, the dura. So the reason it's called epidural is because it's not into your spinal cord, but it's injected into the area just outside your spinal cord. We're going to watch a video in just a second of how an epidural is performed. They block the transmission of pain signals from the nerve fibers where they enter the spinal cord. So it basically floods your spinal cord with the drug so that no nerve impulses are traveling past that point. And then it numbs everything from that point down. And then what you see with those two is that gravity has an effect on those drugs. So if epidurals are very effective, they're about 90 to 95% effective. Sometimes you do see things like hot spots, and like some moms, epidurals don't work. It's very rare, but it happens. And so with hot spots, what happens is if you're lying on one side, you can't really lie flat on your back after you get an epidural, but if you're lying tilted to one side and the medication is affecting one side more than the other, then that's when you have hot spots occur where it's just missing, it's just missing that one place where one nerve, like I had a mom one time who had a hot spot like between her belly button and her hip, and she just could never get that pain to go away. So she had complete numbness from like her rib cage down, except for this one like fist size spot that just always she could feel the contractions in. And it was very frustrating to her because they couldn't get the hot spots to go away, even though she had an epidural. So she ended up turning the epidural down. So neuroaxial analgesics are done by a specialist or an anesthesiologist, either using an anesthetic drug or a combo of a narcotic and anesthetic. Common drugs, so this is complete to partial numbness, complete muscle weakness, decreased control over the legs, inability to urinate. So if you get an epidural, you end up with a catheter as well. Common drugs are called cane. So the narcotics are morphine, fentanyl, sufentanil, and then anesthetics are the cane drugs, and it's carbocaine, marcaine, xylocaine, nesicaine, and rifabucaine. Some of these, like I said, I'm not a medical professional, but you may hear some of these. I listed all of those. So you may hear some of these names tossed around, and you can always ask, what medications do you put into the IV if you want to know. A block is medication that interrupts transmission of pain impulses, creating numbness. So that's similar to, the difference between an epidural and a block. An epidural is around the spinal space in the fluid, and then a block would be inside your spinal cord. So it's completely blocking all pain and I think those last a lot longer. They're not as easily retracted. Local anesthetic is going to be, so there's not as much of the local anesthetic use. However, you probably saw it in that video where they did the perineal for an episiotomy, right? So blocks nerve endings in the affected area from sending pain impulses over the nerve fibers to the spine and brain. So there's several types. There's a paracervical, which is when they numb your cervix with local anesthetic. There's the pudendal nerve, which the pudendal nerve goes through your hip joint, and it's sort of like it's the birth canal, like the vaginal canal, and sort of the areas around that. And then the perineal, which you'll see, that's like when you may get a perineal local anesthetic if you have tearing, even with a midwife. If you have tearing and they need to suture, she may administer a local anesthetic so that you don't feel that. So paracervical and pudendal used to be used a lot more. Nowadays, you don't really see that at all. But if you go back to what I said about where labor pain originates as pressure, stretching, or compression involving tissues in the uterus, vagina, or pelvic joints. So that's that used to be a common pain management method, and then nowadays. Anyways. So general anesthesia is a complete loss of consciousness caused by systemic medication. So general anesthesia, we hope that you would not have a choice to use that in labor. In a second, when we go over the pain scale, you'll see one option. The pain scale has got two extremes, one of them being mom wants to be completely unconscious. She doesn't want to be awake for any of it. She doesn't want to feel any pain, and she also, it's okay, don't stress. So general anesthesia would be where that option would come into play, where mom wants to be totally knocked out and the baby taken out of her. She doesn't want to have anything to do with it. She just wants to go to sleep, wake up, and meet her baby, right? So general anesthesia is used either a gas or an IV liquid medication, reduces pain quickly by reducing or eliminating consciousness for as little as a minute to several hours. Pain is not eliminated, but is reduced. Birthing person is no longer bothered by it. So that's with nitrous oxide, which is sometimes self-administered. Hopefully we'll get some of the hospitals around here doing that soon. So what is the risk with general anesthesia? This comes back to, and I have here, the risk is aspiration, and then it says connect the dots. You see this given commonly as the reason for no eating and drinking during unmedicated labor. So a risk of aspiration so the reason that you can't eat and drink during an unmedicated labor would be because if you're unsuccessful and you have to have a C-section and you're put under general anesthesia, we don't want you to aspirate and inhale your own vomit and have pneumonia because of it, right? So kind of a roundabout. I don't know if you guys feel that way, but it's a very long, far away risk as far as risk management goes. If you really look at what the true risks of, of general anesthesia and compared to the chances that you would actually have to use it, it's pretty far away. So it's often used when complications are emergent or life-threatening, and a C-section must be performed within minutes. Some examples of this would be cord prolapse or hemorrhage. And, where they would, like I said, where they would just say, we have to do this now. You still can ask why, what's happening, but then they may say, we have to put you under and take the baby out. And I actually know someone personally who that happened to, and she's now come to terms with it, but it's definitely something a situation we don't want to have to get to, but that you still need to know about. Gotta understand. So I'm gonna focus now on epidural anesthesia because this is the most common when someone thinks of pain in childbirth and how do we manage it. It's an epidural, and there are definitely some risks and benefits. I do consider this as one of the interventions, even though it is hopefully a voluntary choice that you would be making. It is still a medical intervention. So we're going to touch on this one today instead of doing it next week. So what's the primary benefit of an epidural? No pain. You're relieving the pain. So a lot of this too is statistics, but it's still, I think, important to hear. So 90 to 95% of women, epidurals are effective. Reduced pain is related to contractions and to interventions, such as Pitocin, forceps, episiotomy, cesarean. So we're gonna kind of run through this. Mother can remain clear-headed, think, converse naturally, can rest, and even sleep for a few hours while her cervix continues to dilate. So how is an epidural administered and what is involved? When an epidural is requested, you should get up and go to the bathroom because you're going to have a catheter and hopefully you can maybe have a little time before then. An IV is started with fluids. Mom is confined to the bed after an epidural. There is such a thing as a moving epidural. However, I have never seen it used. Usually hospital policy goes that if you get an epidural or any kind of medication through an epidural, they're not going to let you get up and walk around. You may be able to discuss that if you want to have, there is such a thing as a moving epidural where if they put it in the right spot, if you have an anesthesiologist that is aware of, then basically what they do is they try and numb like between your hips and your rib cage. But it's, like I said, it's something and it's also it's very light medication. Instead of being like a continuous flow of a heavy drip, they up it so slowly that you're able to still feel your legs. But that's another thing where it's like the hospital's liable if you fall, and so they're not. I've never seen. Would they let you
sit in a chair just to like
potentially? Yes, potentially. Well, and like with an epidural, you can still sit in like what it's called, King's Throne, where you put the back of the hospital bed up and then you pull the end of the bed off, so you can still sit up all the way like you're sitting up in a chair. But a lot of times, what you see is if mom needs to move, you have to move her. You have to help her to move her legs and replace her body so that she can get to that position. So mom is confined to bed and has placed on her electronic fetal monitor, automatic blood pressure cuff, electrodes to monitor her heart rate, and often a catheter to empty her bladder. She may need oxygen at times during labor. So oxygen is used when your blood oxygen level goes down. And the reason is because if your blood oxygen level goes down, baby's blood oxygen level is going to go down too, because they're getting their blood oxygen from you. Placing an epidural can take 15 to 25 minutes from the time the anesthesiologist arrives. So this is a little short explanation. I'm not going to read this part because we're about to watch a video, but basically it's kind of how it's done. Pain relief begins to take effect within 5 minutes, but it may take 15 to 45 minutes to reach full effect. So if you see that, it could be 15 minutes to close to an hour before the full effect of the epidural comes into play. Remain into effect until the baby is born and the catheter is removed. However, another thing to remember with epidurals is you can always request that it be turned down. Now, if you were to do that, you will have to wait for the anesthesiologist to come back into the room from wherever he's at and do it for you. So sometimes they have what's called a patient-controlled pump, or PCA, where you have a little button that you can't overdose on because they have it set, but you can press the button and it gives you a little bit more. However, you can't go in the reverse of that. You have to have him or her come in and do it for you. So we'll watch the little short, there's two, I think they're like 2 minutes and then 3 minutes, but this is just an example of how an epidural is placed. Where did my page go? Not that one. This one. Can you go to it for me?
If you are having certain operations, such as pelvic, hip, or leg surgery, you may be able to avoid general anesthesia by...
Sorry, hold on. You get pulled it up twice on me. Okay. Okay.
If you are having certain operations, such as pelvic, hip, or leg surgery, you may be able to avoid general anesthesia by having your operation under spinal or epidural anesthesia instead. Spinal and epidural anesthesia are also often used during childbirth. Both spinal and epidural anesthesia involve injecting medications near the spinal cord. This makes you numb from the level of your chest down to your feet. Advantages of spinal and epidural anesthesia include the ability to be awake during the operation and to avoid the risks associated with general anesthesia. Because spinal and epidural anesthesia rarely cause decreases in blood pressure and other changes that might require rapid treatment, you will have an intravenous line in place so that fluids or medicines can be administered quickly. You will also be connected to various monitors to keep track of your blood pressure, pulse, and the oxygen content of your blood. Prior to receiving spinal or epidural anesthesia, the anesthetist will use an antiseptic solution to clean the area of your back where the medicine is injected. To decrease pain from the needle stick, he or she may instill a local anesthetic directly over the spot where the spinal or epidural needle will be inserted. Spinal anesthesia involves a single injection of medication into the sac of fluid that surrounds your spinal cord. To reach this fluid sac, the anesthetist will pass a needle through your skin, between the vertebral bones, and finally through spinal ligaments and the dura, which is the protective membrane around your spinal cord. Spinal anesthesia begins working almost immediately after the injection is completed. With epidural anesthesia, the needle does not penetrate the dura, and medication is deposited just outside of the sac of fluid that surrounds your spinal cord. Epidural anesthesia may be given in a single dose, or the anesthetist may leave a tiny, flexible tube or catheter in place in the event more anesthetic is required during a longer than expected procedure. Epidural anesthesia takes about 10 minutes to begin working. After the injection of spinal anesthesia or the removal of an epidural catheter, a small bandage will be placed over the area where the needle was inserted. After spinal anesthesia, you will be kept in bed with your head flat for several hours.
Okay, so that's the first little one, and then there's one more that kind of gives a better.
Hey everybody, this video is going to be an introduction to the differences between epidural
Oh, what?
and spinal
I
anesthesia.
thought someone else was
Oh,
talking. I
spinal
was like, wait a second. Okay, sorry. I'm like, yes? Who's teaching? Okay. Here's the second one. Takes way too long to actually.
This animation shows how an epidural.
Okay, so this one is a little different for the same thing. This. And
Is given during childbirth. Epidural analgesia relieves pain without putting you to sleep. It's usually given early in labor. Click the navigation arrows below the animation screen to play, pause, rewind, or fast forward the animation. You will be asked to either lie on your side with your knees drawn up to your tummy and your chin tucked in, or to sit up on the bed and lean forward. Both positions open up the spaces between the bones in your lower back. Your anaesthetist carefully selects a point to inject by feeling for specific bones in the spine. He or she may mark this site with a pen to show where to put the injection. Your anaesthetist will inject a small amount of local anesthetic into your skin. This completely blocks feeling in the area. When the skin is numb, a larger epidural needle is passed into the epidural space, which is the space outside the membranes that surround the spinal cord. When the needle reaches the correct spot, a fine plastic tube or cannula is inserted through the center of the needle. The needle is then removed and the tube is left running from the epidural space to the outside. The tube is held in place with adhesive tape. Your anaesthetist uses the tube to inject local anesthetic or other pain relief medicines directly into the epidural space. Your anaesthetist may attach a pump to the tube so that you can have a top-up when it's needed. It may be possible to control this yourself. This is called patient-controlled analgesia, or PCA. When the need for pain relief has passed, the tube is carefully taken out and the area is covered with a plaster. This is the end of the animation. Click.
Okay, so those are, this is the end of the animation. So one thing that she said is epidurals are typically given early in labor. So that obviously is up to you, but there are some effects of doing that. So the next 2 points here, we have what are the potential side effects of epidurals on mom, and what are the potential side effects of epidurals on baby. I went through a lot of videos on YouTube, and a lot of them had, at the end, it was a nurse practitioner giving the video, and at the end she would say, I want to bust some of the myths about epidurals, right? And then she's like, epidurals don't cause this and don't cause that. And I just sat there and I'm like, how can you even say these things when there's evidence that proves, I mean, there's statistics that show you that that's not true. I was just like, blows my mind. Anyways, so feel free to do your searches on YouTube and go through some of the videos if you have more questions, but just know that not everything you see. Evidence-based birth is just a great resource, and there's several pieces down here at the bottom of this that if you actually go to the Dropbox or go to the digital version of this file, you can click on those links and you can read about all of the, it's her pain management series, which I think is a really, really great resource. You could watch all the videos in this class. I would sit here and let you watch them, but go do it. So anyways, what are the potential side effects of epidurals on mom? Contractions may be slow, labor may be longer. Pitocin augmentation may be used to counteract this. Pitocin is 3 times more likely in epidural labors. Now, this would be if obviously if an epidural is given early on, you're going to have a higher chance of needing something to augment labor later. Blood pressure drops for 12% of women. This is treated with extra fluids and oxygen. So you saw, she said, an IV fluids may be given before an epidural. One of the videos I watched had a really good example of how this is managed. So essentially the reason that they give 3 bags of IV fluids is usually what they give you before you get an epidural. And then she said that the reason for that is we expect blood pressure to drop. And that by giving you 3 bags of fluid, when the blood pressure, it raises your blood pressure so that when blood pressure drops, it's at a normal rate. And so I was just sitting there thinking like, why don't you explain that when you say, you know, it's anyways. So it's common for them to give you IV fluids before an epidural, and that is a preemptive measure so that if your blood pressure drops, you already have a higher level of fluid in your body. So you have a 14.5% chance of a fever over 100.4. That chance increases after 4 hours with an epidural. The birthing person might experience itching, nausea, vomiting, and shivering. Shaking is kind of a normal thing with pregnancy, but like an epidural shake where mom can't control and she's just like, you know, one of the things I do sometimes is I'll grab her arms and move them so that if there's movement, then you can't be like, but it's really weird to see that. So you may not be able to feel the urge to push. You may not be able to push as effectively. 12 to 15 studies show a significant association between epidural and C-section. The risk of C-section generally is 2 to 3 times more likely with an epidural. And this is influenced by what point in labor the epidural was administered. One study found cesarean rates were 26% when given at 4 centimeters and increased to 33% at 3 centimeters and to 50% when given at 2 centimeters. So you have a significantly longer pushing phase on average for FTM as first-time mom, 1.1 hours with an epidural and 0.6 hours without an epidural. One of the things that I'd highlighted to go over too is that you have 3 options for a pushing phase when you have an epidural. I'm going to read them to you. Okay, so pushing with an epidural, you have 3 choices. 1 is to turn down the epidural to give the birthing person sensations to guide her bearing down efforts. 2 is to have her begin pushing by holding her breath and straining with every contraction. And 3 is to delay pushing until the baby is visible at the vaginal outlet or the mother feels the urge to push. So this goes back to when I was talking about the stages and phases of labor, the pushing phase, right? And we said every body is different. What happens if you are 10 centimeters dilated and you don't have the urge to push, but your care provider says, if you choose to consent to a vaginal check and they say, okay, you're 10 centimeters dilated, it's time to push. What do? Do you feel the urge to push yet? Are you assessing that within yourself? Do you feel like, you know, at that point, sometimes you're ready for baby to come, so it can feel very encouraging to say, oh, you're at 10 centimeters, it's time to push, right? But if you don't have an epidural and you don't have the urge to push, give it time. There may be a reason for that. It might be that baby is doing that rotation. We're going to watch a few rotating videos in a second. So to have her begin pushing by holding her breath and straining with every contraction is also a really good way to get worn out before you actually need to get to that point. So what are the potential side effects of epidurals on baby? IV and epidural drugs are considered safe. However, they do cross over into the placenta and therefore affect the baby. So a lot of the things you'll see in the other handout I send you is they have like specific amounts for like how much of the drug, and obviously your care provider in that case would be the one to make those decisions. But if someone is going to administer the epidural or the IV anesthetic, then they're going to hopefully be doing it at a safe amount so that if your baby does get it, then it's still, they consider it to be safe, still an opiate, right? If mom's blood pressure, if mom has Pitocin, contractions can be long and strong and can reduce baby's heart rate. Do you guys, we'll talk about Pitocin next class. If mom's blood pressure drops, decreased fetal heart rate, decreased oxygen supply. If mom develops a fever, baby's heart rate may become rapid, tachycardia. Baby may develop a fever as well. And if baby develops a fever, they may be treated for an infection. So at that point, you're getting administered antibiotics either during labor or immediately after labor. Mild to severe fetal distress is diagnosed within 10 to 15% of babies after epidural. Generally, these changes do not affect baby's health at birth, as measured by APGAR scores, but signs of fetal distress can lead to C-section. Baby may not be able to rotate as well into the correct position for birth, may be increased risk for forceps, vacuum extractor, or cesarean. I have personally seen this happen, and the doctor explained to me later, he actually came into the room and had a conversation with me, thanking me for being there and being supportive, and I had a chance to ask him a question. And his response was malposition was the reason for C-section, and that malposition could have been a result of the epidural. And so it's something to think about, if your baby if you can't feel your legs and you can't feel what's happening, your baby is the one who does that work that you can't see on the inside. And if they don't know what's going on, how do you expect them to get into a good position? After birth, there may be subtle side effects for the baby, such as decreased sucking ability, poor latch during breastfeeding, or more difficult to soothe. And then this is what I said, the links, there's 1, 2, 3, 4, 5. These are just specific articles, but you can do your own. Evidence-based birth is still just the best resource because she takes everything that's out there and compiles it and presents it in a way that's understandable. And there's articles on breastfeeding, how breastfeeding is affected by epidurals and everything else. Comfort measures practice. So what are my options for pain medications, benefits and risks of each? So let's go through them and see if you guys kind of can get a grasp on this. So as far as the a gas or a systemic that goes into your bloodstream and is a short acting, something like a narcotic or a synthetic narcotic, what do you think would be, who wants to do it? You guys can jump into, who wants to do brain on this one? So not an epidural, but something that they would inject into your IV. That would be a short acting, 2 to 4 hours. Yes. Morphine. Maybe morphine, yeah. What would be the benefits and risks in that situation?
I just think it would be a little more aggressive than an epidural.
Mm-hmm. There'll be a risk. Mm-hmm. Mm-hmm. Benefits?
Reduce pain.
Mm-hmm. So that would be one that is it reduces pain but doesn't completely eliminate it. So you have to just doesn't affect mom as much, right? But she still has those peaks. She still feels the peaks. Alternatives, right? Alternatives would be your other toolkit of that's the word I was trying to use, non-pharmacological pain management. What does your intuition tell you? Obviously, you're not in a situation.
Try everything.
Right. What else have we talked about that we want to try? And are you okay with, in that sense, I'm going to say, can we get through if you were to request a pain medication, and I know that you really want to have an unmedicated, like your goal is an unmedicated birth, then I may come in and say, I know you're having a lot of pain right now. Can I get you to do 3 or 4 or 5 contractions up walking around with me? I know it's going to hurt. It's going to be really uncomfortable. After that, let's talk about it again. And so hopefully at that point we would be able to move on to the next thing. So what happens if we do nothing? Keep going up or down. Yeah, things keep on being the same. So as far as pain management, we always want to be, the reason I showed you that very first video with Rebecca Decker is so that you understand and can kind of start to conceptualize the difference between pain and suffering. Because that's going to be, when we move on to this pain management scale, you know, when you're in labor, you don't know now how you're going to react to that. How is your anxiety level going to be? How are your coping mechanisms? What's going to work for you? You don't know, right? So knowing the difference between pain and suffering is important, because I may say, I understand that you're in pain, and this is something that is normal and natural for labor, and we're going to try and cope with the pain. However, I don't want you to be suffering. If you're suffering and you feel like it's beyond what you can handle, then let's talk about pain management. Let's talk about pain relief more than just pain management. So like if I were to have that situation with you where it's like, let's try and handle 3 and 4 more contractions and get through it, and you say to me, I am suffering, I cannot deal with this, then at that point I would probably say, okay, I'll go get the nurse for you and we'll talk about some pain relief, right? So the difference between pain and suffering is something to have in your toolkit to say, at this point, I'm not handling it well anymore. I'm not staying on top of it. I've lost my ability to hold on to those contractions. And what I am going to work with my clients on is staying on top of that every single time, so that you don't lose that ability to hang on to the idea that you still have a break. You have a break coming up. Yep, you got to unmute yourself if you want to. Hey, Joy, are you talking to me? Are you talking to me, Joy? You got to unmute yourself. Oh, no, okay. I couldn't tell.
We were talking about coping mechanisms that you were talking about. Yeah,
just making sure. So we will move on now to the pain medications preference scale. Now, if you put this one in your purple folder, I don't know if you guys put it in there, but it kind of cuts off one side of it because it's used so much of it. So I'm going to take it out of the folder. Okay. So what you see here, we're going to skip down. It's about labor pain. We kind of covered most of this. 4 factors that determine whether to use pain medications: your desires, childbirth education, support and assistance, and your labor pattern. So this is going to be how we'll use this scale. And part of your homework is going to be to go over this scale. We don't have to go through every individual person's preferences, but this is going to be, and if you have questions about how to do it, feel free to send me a message or call, whatever. But before you decide your pain medication preferences, you learn about the labor process, which we've done, comfort measures, self-help techniques, and the various medications available. How are they given? How do they work? What are their benefits and risks? How do they affect your baby, your labor, and you? Childbirth education courses, healthcare providers, professionals, books, videotapes, internet, and your family and friends can all give you helpful information. Also examine your personal feelings about birth, pain, and your support system. How much help do you want, or can you realistically expect from your partner, from your doula, from your caregiver, from the nursing staff? So you're going to use this scale on the other side, on the second page, to understand the level of assistance that you will need. Use the numbers to indicate degrees of desire to avoid pain medications, and be sure everyone who will be with you during childbirth understands how to help, no matter where you are on the scale. So you and your partner should go over it separately. and each select the number that most closely reflects your own desires about what the birthing person uses or avoids pain medication. The two of you do not agree. You should discuss your opinion and find ways to ensure that you have the support you need for your preferences. When partners often select 0, wanting to support whatever the woman wants. So it is important to have this conversation, and that's why I want you to do it on your own and kind of come to an agreement, or at least understand where one person, if there is a difference, you know, where you guys stand. No one knows in advance how long or painful labor will be and whether there will be complications. Even with all the unknowns, your desires as expressed, the scale will help you be a valuable guide to those who are here to help you. Always remember that this is your birth experience. Recognizing and expressing your desires and needs to your loved ones and caregivers will help you get the kind of support you need and contribute to a rewarding experience and a positive, lifelong memory of your baby's birth. So the pain medications preference scale goes from +10, she wants to feel nothing, desires anesthesia before labor begins. So this one says an impossible extreme. She has no interest in helping herself in labor. She needs to know she will have pain and needs reassurance. So I'll let you guys read between this, but I want to read the last one too. Wants no medication, even for a cesarean delivery. An impossible extreme. Encourage her to learn of complications that require painful interventions. Help her get a realistic understanding of risks and benefits of pain medications. So you guys, this will be your homework. I want you to go over it and read all of the answers and kind of figure out where exactly you fall, because next week we'll go through and I want each person to kind of give me a point of where you think you fall on this scale. It's going to be important to figure out for you what kind of support you currently have, what kind of support you need, and then understanding the difference in roles in the birth setting of, you know, like I said, your nurse is not going to come into the room and say, would you like me to rub your back? You know, they're going to be more, it seems like you're in a lot of pain. You know, let's get you some relief. Can we talk about pain medication? So if it's in your birth plan that you want to avoid pain medication, you may consider what that means as far as, you know, what kinds of steps do you need to take now to set up yourself for success, and knowing those non-pharmaceutical pain methods. So the next thing we're going to do is practice comfort measures. Do you want to bring, or does he have his phone with him? Yeah, and we'll be good in here with her plan. No big deal. Yes. So I'll go ahead and read your homework. Discuss pain med scale with partner. Discuss how to make pain medication decisions during labor. And I want you to discuss or journal the following questions. What does pain mean to me? How do I usually deal with pain? How does our society or my upbringing tell me to deal with pain? What can I do now which will help me to accept the normal pain of labor and to not fight against it? So I want you to really spend some time with those questions. There's a little extra space on this page if you want to write on there. If you don't want to actually journal it, it's obviously up to you, but it's always interesting to kind of give yourself a chance to walk through those questions. So hip squeeze and counter pressure are going to be the two comfort measures I want to show you. And then if you want to practice some actual labor positions, I think those are always really funny to do because some of them seem like they're kind of crazy, but they're actually maybe comfortable when you get down to it, but you won't ever really know how they feel unless you do them. So everybody up. Are you guys lounging on the couch over there? I see you. I see you lounging. He's like, yep. Okay, so comfort measures. Who wants to be an example for counter pressure? Got it. I got it. Okay, so if you'll put your hands, you're gonna stand like this, and I'm gonna tip the screen so you can kind of see, and then I'm gonna find a spot that feels comfortable for you. So give it your back. Okay, so counter pressure. What you're gonna do is you're gonna have one hand on her hip, kind of give you a starting point, and then you're gonna find where her hip bones are and where the sacrum comes down to. So counter pressure is gonna be down. Does that feel okay?
Yeah.
Pressure all right? How does it make your hips
It's a little looser.
Looser. So,
Right?
you want to try it
Sure.
and see if it feels like the same spot? So you feel for her sacrum, and then you can use the butt of your hand, or you can do like your full fist flat and push. And then the chairs are kind of flimsy, but when you have something like a couch or a chair to hang on to, you'll have a good kind of pressure to put against what he's doing.
How to go against it.
Mm-hmm. Does it feel the same? So you
No, because it's going to
so you use this part of your hand or that, either one, whichever feels comfortable to you. So when you do counter pressure, when you have, you guys want to try? You want to try? Did you hear the description? Okay, so what you're looking for is you're looking for, touch your back. Yeah. So you're looking for a sit-on. And you're going to find like your top of your finger and where you're pushing. So spread your legs and give yourself a good solid stance. Counter pressure is like. So kind of get used to it.
There's pressure there.
She's like, I'm going.
So that would be.
You want to try it right here? You can try it right here. Can I show you where? Okay.
Let's see when you're feeling. What's that going to help with?
So counter pressure is going to help with back labor. Counter pressure is going to help. Okay, so with my pelvis model, I'll show you guys. But the way that when you press on the back, it sort of allows your hips to open up just a little bit. So it releases some of the pressure that you feel in your pelvis, and it doesn't, and like in the front, it's hard to like get a good feeling for what to describe the way it feels. Yeah, but so counter pressure, when you push on the back of your sacrum, it sort of allows your hips to just come out just a little bit, and it's not a lot, but when you have a labor contraction or when you're having back labor, like you have the pain in your back, it can be huge for that. I've even had moms whose babies in a good position, and the counter pressure was just the only thing that she wanted. And it was like, by the end of it, you know, you got dad to practice a couple times. I hadn't met with them at all previously. So finding out questions you can ask are, how's the pressure, up or down? She may not be able to vocalize very well. Besides, don't do that, right? If it doesn't feel good. So searching for that information as far as like what can make it better, you're looking for. It's usually either up or down. That is where you would put the tennis ball. So counter pressure would be like, how are you guys on the video end? Are you guys figuring it out? Good? Okay. So this is where you would use the tennis ball, and you can kind of get that counter pressure against the sacrum. So the other one is a hip squeeze. And a hip squeeze is going to do the same thing, only a little bit more intensely. So with a hip squeeze, what you're looking for is to find the top of your hips, and you're going to sort of come around to the side, and the pressure is going to go up and in. And it feels like if you do hip squeeze right, it should feel like your hands are just about to slip off. So you're kind of wanting to come down and push up. So who wants to do this? Have you? I haven't done any of this. Well, I'm going to be having people do this. Yes. So hip squeeze, you find where the hips are. Let me do any. Okay. So you find her hips, and then a hip squeeze will sort of be like, how's that?
Oh. Yeah, I feel it.
Yeah.
Oh, so you're squeezing here.
Yeah, so you're squeezing sort of like just the pelvis. Let me get the page. So okay, so with a hip squeeze, you're kind of coming in like right here on the back side, right? So it's like, okay, I'll show y'all. So it's this image is what I'm showing them, and with the place you're coming in is like right here, but on the back side.
Yeah.
Does that work? Yeah. Good. Okay, and so this does two things. The first thing it does is it allows your pelvis to do what it wants to do to let the baby come down. So when you squeeze the hips, you're sort of opening the pelvis up like that, and it opens the pelvic inlet, which is where baby's head is passing through, by just a little bit. So it might ease that feeling of some of the pressure, some of the intensity. It also the reason the counter pressure and hip squeeze feel so good during labor is that gate theory. If you have something that feels good during a contraction, you may get stuck on it in the sense that you want it every time because the pain is not as bad because you're kind of focusing a little bit on these things that feel a lot better, right? Did you guys get the hip squeeze in a place that feels good? Okay. The next thing to do, let me pull back that labor positions page. Did you guys get the hip squeeze? I know that one's a little bit harder. Did you find a place where it felt like your hips were like a little, kind of, sort of?
Kind of, sort of. It's hard when we're not there for you to show us.
Yep. I will get you guys.
Make sure we're doing it right.
Yep. Well, next trip to Atlanta, you're on the list.
We're coming back to Birmingham soon too.
Yeah.
Oh, good. Okay. Well, we'll figure something out. No.
Either this next weekend or the next weekend.
Oh, cool. Well, if you're here on Saturday, you
CBE.
should come to the class in person if you can.
Yeah,
we will.
That's a good idea.
I was thinking
Definitely.
about that.
Okay, so labor positions. What's your favorite? Have you tried any? Yes. Yes. No, that feels good though. So drop your weight. Drop it all and let him.
Oh, yeah.
That's great. That's a great one. I got Esteban to do that. So can you see? You see what they're doing? He's got her weight, and she's got. You have nothing on your legs, but you still got that squat. And so another good way to do that is the same thing. Only if you spread your legs, or if you sit in a chair. So do the same thing. Yes, wider. So any positions. I'm gonna put the computer right here so we can get a good. So any labor positions that you try, so you want to point your knees out. So any labor positions that you try when you're squatting, yeah, it's going to be like this. And it's straight around, right. And then when you're laboring, watching knees wide. The wider your knees, the more space baby has to come down now. But that is an excellent one because when you can get in a squat, deep squat, without having to use your legs to stay up, you're using less energy and you're still getting that good squat position. Yeah, you guys are doing great. Okay, so another one. Let's see. Does anybody else have a favorite? No? I want to try this one. You guys want to try this one right here? This is the hip squeeze with supported weight. So this one is going to be, I'll show you the one I was pointing at. Is this one right here? And you can take off the support person, and basically what you're trying to do is you're trying to get mom into a good squat, and then partner holding her weight so that she can lean back and still get a good squat without, it's kind of what you guys are doing. Yep. You guys want to try it? There you go.
Counter pressure.
And then, yes, exactly. So then I could be behind you. And then,
Like 15 seconds of speed.
So let's try again. Does that feel good to you? You see that kind of sort of? Okay. So what you're going to do is you want to have more of your weight back. So lean back to the sheet so that you're holding her hand. So we're going to feel a little better. And then you come together just a little bit and you lean back. You want to try?
Yeah.
So the other way to do this one is holding like a sheet, or if you get a rebozo, it's basically a scarf. And you can do the same thing where you like wrap it around your waist, or where you hold on to it's a long piece and you're holding on to the middle, and you're holding on to the two ends. You get the same effect, just a different way of, you just get it right, kind of, right, because you can kind of pull, instead of being like actually holding onto your arms, essentially what you can do is you can hold onto that rebozo and you can pull, give slack or not, and you kind of like rock back and forth if you're moving at all.
What was this one? It looks like the feet are off the ground.
Yeah, so
Feet
you
are
want to try it? You maybe can not enough arms on the chair. No.
Guys, help.
Okay. Okay, so yeah, so you're gonna sit facing that way. So the one we're looking at is, let me show you, is this one. Which is kind of an interesting, if you have a chair. That's how we started. Exactly. You're gonna sit on his lap, one leg over, and then you're gonna kind of spread your knees apart and let her drop down. You can, wherever feels comfortable, you can hold on, like hold your hands over behind your neck. There we go. That might feel good. So then you can also do It's up to you guys, whatever feels comfortable. Some of it, that's why I say, like, try these things. It might feel weird, but it's better to get the weirdness out. And then when you actually are in labor and you're like, hey, let's try that thing that was really weird, but like it kind of felt like it might feel good. Right? Okay. Positions for back labor. Let's see. Active labor. So the other one that's really good that you may not expect is this. So sitting on a chair backwards. You can lean over the back of the chair. You have no pressure on your perineum. The same goes with like sitting on the toilet. You can sit on the toilet and have contractions. Your baby won't be born into the toilet, but it feels so good to have a chair with a hole in it where you can sit down. You can do facing the toilet backwards as well. The last birth I attended, the baby was born in the bathroom because mom, for the last like hour, labored sitting on the toilet because that's where she was comfortable. She couldn't sit down. She couldn't get comfortable anywhere, but when she sat down on the toilet, she didn't want to get up. So it's kind of interesting. Other labor positions. So do the figure eight. Have you tried? I remember you saying that, but figure eight with your hips. Hey guys, I'm up here, eyes up here. No, I'm just kidding. So this one seems really simple, but it's actually a really great tool to stay moving. So you're gonna draw a figure eight with your hips, or you can just rock. It becomes kind of a rock, but when you're moving, you can't hold tension. So this was, you guys weren't here for the first class, but Joy was. Clint and Deanna weren't. I made everybody get up and dance to the Baby Mama song the first time around. But
Deanna's too scared to be on camera.
Oh, that's
so.
fine. That's totally fine. You guys can do it in the privacy of off camera. Perks of not being here. Have you had any Braxton Hicks yet? Or at all? Only one? And how did you feel about it?
I have them all the time.
You do? That's awesome.
Yeah.
I think that is it's the greatest opportunity to practice your movement. So the next time you have a Braxton Hicks contraction, I want you to get up and move around just a little bit and try and not sit through it or be solid. Getting into that habit is the absolute best way to break the thought cycle that being is like, right? Like the way that you tense up. So the figure eights and the rocking, if it's like this or wherever, when you have a Braxton Hicks, train your brain to say coping mechanism starts now. And so then when you have real contractions, coping mechanism starts now instead of immediately defaulting to trying to get away from that. Okay, do you guys have any questions about anything? Questions, concerns? No? Okay, so I don't really have anything else past this today. We've gone a few minutes past in other classes, so if you guys don't have any questions.
Ow!
Okay. Well, on the video chat end, the tennis ball. There you go. Yeah. So practice the.
This is Gucci's tennis ball, so he's very upset.
Practice the hip squeeze and the counter pressure a couple times too, so that you guys can try it. Well, I'll show you when I see you, but even just kind of moving around with it and trying to figure out what feels good. I don't know if you heard me telling them the questions that the partner can use is during labor, when the birthing person is kind of not really able to do a whole lot of responding besides usually saying something like, don't do that anymore, that's not good. What the birthing person can do, the partner can do is say, how is the pressure? So is the pressure too intense, or is the pressure, and you want to basically give them the words to use because a lot of times they're not going to have them. How's the pressure, and up or down? Would you like me to move my hand up or move my hand down? And that can be a good way to figure out where is the right spot. Because with those two things specifically, you got to literally get exactly the right spot. And sometimes it doesn't feel good if you're not in that. So anyways, cool. Well, I will see both of you guys. Talk to you soon. And thanks for joining us.
Bye.
Thank you, Kristen.
Yeah.